This presentation will provide a brief review of the common anesthetic medication propofol. Propofol, or Diprivan, is also known as 2,6-diisopropylphenol IV anesthesia. It typically comes in a 1% or 2% lipid soybean emulsion. Its pharmaceutical class is that it's an IV anesthetic, sedative, and hypnotic. Propofol's primary mechanism of action centers around its ability to modulate aminobutyric acid receptors, or GABA receptors. When GABA receptors are activated, transmembrane chloride conductance increases, resulting in hyperpolarization of the postsynaptic cell membrane and subsequent inhibition of the postsynaptic neuron. Along with its anesthetic effect, propofol has a clinically relevant influence on the respiratory and cardiac function of patients. The effect of propofol is dose-dependent, and at hypnotic doses, in healthy patients, the effects are comparable to that of a state of natural sleep. However, at therapeutic or anesthetic doses, propofol depresses the activity of the medullary respiratory and vasomotor centers, causing respiratory depression, vasodilation, and myocardial depression. This slide is a brief visual guide to the hyperpolarizing effect of propofol on GABA receptors. And for a dosing overview, induction dosing for propofol is 1 to 3 milligrams per kilo. Sedation dosing is 25 to 100 mics per kilo per minute. Anesthesia maintenance at 100 to 300 micrograms per kilo per minute. Its onset is less than 1 minute, and its peak is 1 minute. Its anesthetic duration is roughly 3 to 8 minutes. It's known that propofol is a highly lipid-soluble medication demonstrated by its high oil-water partition coefficient, and it's thought that this high lipid solubility is the reason for its very rapid onset of effect. Propofol has a redistribution half-life of approximately 1 to 2 minutes, indicating that the effect of a typical bolus injection will be terminated within 3 to 4 half-lives, or 3 to 8 minutes. Central to peripheral redistribution is the primary process in which the pharmacodynamic anesthetic effect of propofol is terminated. Propofol's metabolism and elimination. In patients with normal hepatic and renal function, propofol has a high hepatic extraction ratio that accounts for approximately 60% of its metabolism, while the other 40% can be accounted for by the kidneys. There is some thought that pulmonary metabolism or clearance is also a factor. Hepatic mechanisms are the hepatic mechanisms responsible are the CYP2B6 system that hydroxylizes the propofol molecules. Propofol also undergoes glucuronidation before elimination. At elimination, we know that propofol has an elimination half-life of approximately 4 to 6 hours, substantially less than the other IV anesthetics. This difference, coupled with propofol's very short redistribution half-life, helps explain why propofol, given as a continuous infusion, has a substantially shorter duration than other IV anesthetics after its termination. The metabolites of propofol are eliminated by the kidneys. It's noted that only 1% of an administered dose of propofol can be recovered in the urine without alteration, while approximately 80% of the dose can be recovered in the urine in the metabolite state. Indications for propofol. Propofol is considered a mainstay of various anesthetic cases, ranging from monitored anesthesia care all the way to long duration and high acuity surgical cases. It's also common practice to use sub-anesthetic doses of propofol to achieve postoperative anti-emesis, and in some cases, propofol is even used to attenuate intraoperative bronchoconstriction. Propofol's contraindications. The most notable contraindication for propofol is a known hypersensitivity to propofol or any of its components, specifically eggs, egg products, soybean or soy products. Other considerations. Caution is urged in patients with cardiac dysfunction because they typically have an exaggerated hypotensive response to propofol. Additionally, a lower propofol dose is needed in hypovolemia because a greater fraction of the cardiac output goes to the brain. Pain upon IV injection is often a patient's last memory before a surgical procedure, and some practitioners recommend a dose of lidocaine to suppress localized sensation before propofol administration. In cases of extended propofol infusions, propofol infusion syndrome is a risk. It can be seen in pediatric or adult patients with infusions greater than 48 hours at high doses of greater than 4 milligrams per kilo per hour. Some of the signs and symptoms are metabolic acidosis, rhabdomyolysis of cardiac and skeletal muscle, arrhythmias, myocardial failure, renal failure, hepatomegaly, and death. So propofol should be used with caution for sedation in critically ill children or adults as well for long-term anesthesia. In this section here are a list of links to provide you with more information about propofol. And lastly, this is the reference page. Thank you.